Okay, so this member Padma Priya asked that what is the use of TransTubular Potassium gradient TTKg in ICU. So I was trying to figure out how to answer these questions. So fortunately, I am going for some work to my one of the very good colleague of elder brother sort of nephrologist, which is Dr. Sandeep Saxena. I had some work there, so we'll go there and ask him the question directly. So let's check out. So I have reached. Two things I forgot to tell you. One thing was that he was having severe pain today morning, and he had a root canal today. So he was in severe pain. I'm not sure how much he will be able to talk. Secondly, why I want his opinion is he has been to Canada, and during his nephrology fellowship, he has done a lot of work on the renal tubules and anion gaps and blood gases for that matter. So just want to have a discussion regarding this TTKg with him.
That is Dr. Shilpa Saxena. She is pediatric nephrologist, and he is Dr. Sandeep Saxena. He is very much in pain, but now he is agreed to answer this question. Sir, how is your pain now?
It's better now.
So can we have that small discussion regarding TTKg?
Yeah, I will try.
So sir, this is a question which is asked by Dr. Padma Priya Sukela, and she asked that what is TTKg and how it is useful in ICU.
Okay, so
Means transtubular potassium gradient.
okay, so TTKg is transtubular potassium gradient. This TTKg is basically used in the diagnosis of the cause of hyperkalemia. Whenever patient is having hyperkalemia, we need to know whether it is a secretory defect, kidney is not able to excrete it out, or it is because of overproduction from the cellular compartment. So we do TTKg. If the value of TTKg is 4 or more than that, it shows that kidney has got a normal tubular secretory function.
Means basically we are testing whether kidney is able to secrete potassium from distal convoluted tubule or not.
Yes.
If it is secreting a good amount of potassium, then TTKg should be more than 4 or 6, like that. And if it is not secreting, then it will be less.
Yes. So basically, in the distal convoluted tubule, there are pumped H plus K plus ATPase, which actively secretes potassium into the tubular compartment from the blood compartment. And this function is based on aldosterone action. So whenever the kidney function is all right, aldosterone levels are okay, and receptor is working normally, then patient is able to excrete out or secrete out potassium in the tubular compartment, that is in the urine, actively in face of hyperkalemia. It will be never less than 4 with a normal kidney if there is hyperkalemia.
Means aldosterone causes water and sodium absorption and asks kidney to secrete potassium.
Yeah.
So if it is aldosterone is present, potassium secretion will be maintained.
Yes.
So basically by TTKg we are seeing the capability of distal convoluted tubule, how it is handling the potassium, and indirectly we are seeing the action of aldosterone.
Yes.
So sir, before it's using its utility in the ICU, can you tell how we calculate TTKg?
So basically, we need to calculate TTKg. We need to know the ratio of tubular potassium divided by the serum potassium. Since we cannot take the sample of urine from the tubular compartment of the kidney, so we do neutralization mechanism. So we do urinary potassium divided by serum potassium, which is further divided by urinary osmolarity divided by serum osmolarity.
So 4 values we need. One is the urine potassium, serum potassium, urine osmolarity, and serum osmolarity.
Why we do osmolarity? Because in the after distal convoluted tubule, the only action which remains is water absorption through ADH. So whatever water is absorption, it will concentrate the urinary potassium. So by dividing the ratio of urinary osmolarity by serum osmolarity, we basically neutralize this effect.
Means the absorption of water component, we are neutralizing it. We are just focusing on the potassium secretion.
Yes.
So now we'll take now the question which was asked, that how it is useful in ICU. So two scenario. One is hyperkalemia, the patient is having hyperkalemia, and the other is patient may be having hypokalemia. So in hyperkalemia, we want to know the normal response of the kidney should be, it should excrete or it should secrete potassium more from the kidney. So this is the normal response. So sir, in hyperkalemia, what should be the TTKg gradient?
It should be more than 4.
More than 4. Some books say 6, but it should, you understand the concept. If there is a hyperkalemia in the body and the kidneys are working fine, it should secrete more potassium from the distal convoluted tubule, and therefore TTKg should be more than 4 or 6. Now suppose there is a hyperkalemia and TTKg is less, means potassium is not being secreted by distal convoluted tubule. So what could be the reason?
So this we will cause a secretory defect. So the cause of hyperkalemia in this case is kidney is not able to push out or secrete out potassium in the urine. And this could be because of the tubular structural damage. This could be because of hypomineralocorticoid action, or there could be some receptor inactivity even with normal tubular structure as well as normal mineralocorticoid level.
So for the sake of simplicity, we divide the causes into 2 factors. One is either aldosterone is not present, aldosterone deficiency is there. That's why the body is not able to absorb sodium and water and secrete potassium. So, and the other is, other causes could be aldosterone resistance or other causes which sir said. So, how will we test it? By fluorocortisone. We'll supplement the aldosterone agonist sort of a thing, which is the most common is the fluorocortisone. And we'll give fluorocortisone to the patient. So, it will act like an aldosterone. So, if the aldosterone deficiency is there, the sodium and water will be absorbed and potassium will be secreted. So in hyperkalemia, the TTKg gradient which was low, for less than 4, now it will be more than 4 to 6. That means we are dealing with aldosterone deficiency and we need to work it out. Now after aldosterone giving also, the TTKg gradient is not picking up. That means there is some other, either aldosterone.
Then there are 2 other possibilities. Either the receptor is not working properly.
Resistance.
Like in, or there is some structural damage, like patient has got obstructive uropathy or some tubulointerstitial nephritis where structure itself is damaged.
So this was regarding hyperkalemia, and in hypokalemia, what could be the normal response? The patient is having hypokalemia. So the normal component response of kidney should be to less secrete the potassium and preserve in the body. So TTKg gradient should be low, less than 4 or 6. So if hypokalemia, TTKg gradient should be low. But suppose patient has hypokalemia and TTKg gradient is more, means there is some problem with the kidney and it is not able to adjust according to the body's potassium. So one of the cause could be
like potassium wasting from the kidney.
So aldosterone excess could be one of the cause. Usually such patient present with hypertension also, sir?
In such cases where we find mineralocorticoid excess, such patient have TTKg higher and they present with hypertension also.
So hypokalemia, TTKg gradient more than 4 and 6, patient is having hypertension. So usually we are dealing with aldosterone excess, and then we need to work it out like that. So this was in short about TTKg gradient. If you still have doubts, you can post in the comment section what you want to know. And thank you, sir, for talking this way. Sir was still having pain. There is a local anesthesia effect there. So sorry for that. Now we'll have some treat for sir. He will eat something. Thank you.